Welcome to the deep dive. Now, if you're working in the emergency department, especially in a busy place like a level 1 trauma, STEMI, and stroke center, things happen fast, really fast.
Absolutely. It's all about instantaneous action, right? You're running complex protocols, life-saving stuff under just immense pressure.
Exactly. You know what to do.
Yeah.
You initiate the DKA protocol, you get the TPA ordered, you slap on the BiPAP mask, that's the what.
And that procedural knowledge, that what, it's absolutely fundamental. You can't survive in the ER without it. But for really sharp critical care nurses, especially those of you mentoring newer staff or the ones who just know what's coming next, before the monitor even alarms, the real edge comes from knowing the why.
That is spot on. And that's exactly our mission today. We're going to take some of those really chaotic, high acuity situations you see constantly and trace them backward.
Right. We're drawing on a pretty practical guide to ER pathophysiology here. The idea is to give you that shortcut, that link between the disease process, what's happening at the cellular level, and why it dictates every single intervention you choose, every priority you set.
Think of this deep dive as like a mental framework. Doesn't matter if you're newer to the ER, maybe building that critical thinking foundation, or if you're a seasoned pro looking to, sharpen your judgment, refine how you mentor folks.
Yeah.
Connecting that underlying pathology, the why, to the protocol, the what, that's your absolute greatest tool. It shifts you from just reacting to, truly orchestrating the care.
From following orders to anticipating need. Big difference.
Huge difference. Okay, so let's unpack this. We'll start with the absolute most fundamental concept. The one thing that defines pretty much every critical patient rolling through those ED doors, no matter what their chart says, is the chief complaint. So when you strip everything else away, all the complex diagnoses, the comorbidities, the laundry list of symptoms, what's the absolute core job of an ER nurse?
Well, the source material puts it really simply. At its most basic, your goal is making sure tissues get oxygenated blood. That's it. That's perfusion.
Perfusion. Everything comes back to that.
Absolutely. If someone is critically ill, doesn't matter if it's sepsis, a massive GI bleed, a huge MI, the common denominator is a failure of perfusion somewhere. Always.
And when tissues don't get that oxygenated blood,
it's immediate trouble. You get hypoxia first.
Yeah.
The cells are basically starving.
Starving for oxygen?
Exactly. And that cellular metabolism just shuts down, which leads pretty quickly, actually, to cell injury, then organ dysfunction, and if it goes on too long, irreversible cell death, necrosis.
So recognizing that perfusion failure, that's step one.
It's the key. And to help categorize where that failure is happening, the source uses this really useful symbol analogy. It applies to almost every kind of shock, every critical instability you see. It's the perfusion circuit.
The perfusion circuit. Okay.
Yeah, it breaks down the whole circulatory system into just 3 essential bits. If perfusion fails, it's because one of these 3 has gone wrong. And figuring out which one, that tells you exactly where to start with treatment.
Okay. Component number 1.
The pump. That's the heart, obviously. If the pump fails, the engine just can't generate enough force to push blood forward.
So like cardiogenic shock.
Classic example. Maybe a massive heart attack takes out a big chunk of the ventricle, or someone's in end-stage heart failure. The muscle's just weak and floppy. They've got fluid, the pipes are okay, but the pump itself, it's just not strong enough.
Got it. Component number 2.
The fluid, the blood volume itself. You can have the best pump in the world, but if there's not enough fluid in the system, it's got nothing to push.
Hypovolemic failure.
Right. Trauma's the obvious one, massive hemorrhage, but also think severe dehydration, big burns, or, like we'll talk about in a bit, the kind of insane fluid losses you see in DKA. If the tank's running empty, you just can't maintain pressure to perfuse those vital organs.
Intense. And number 3.
The pipes, the vasculature, your arteries, your veins, the whole system that directs the blood and keeps it under pressure. And honestly, this failure can be the trickiest one.
How so?
This is distributive failure. It's not necessarily that the volume is gone, but the container, the whole vascular system, has suddenly gotten way too big.
Okay.
Think of it like the pipes just massively dilate, or they get super leaky, or both. The fluid's still technically in the body, but the space it has to fill is now enormous, so the pressure just tanks.
Sepsis.
Sepsis is the absolute classic example you deal with every single shift.
Yeah.
Widespread vasodilation, leaky capillaries, classic distributive shock.
That framework pump, fluid pipe, that's really powerful.
Yeah.
Because when that crashing patient comes in, you can immediately start thinking, okay, is it the pump? Is it the volume?
Yeah.
Or is it the container?
Exactly. And it stops you from making critical mistakes. You wouldn't slam a patient in cardiogenic shock with liters of fluid, right? You'd overload the failing pump and drown them.
Right.
And conversely, you wouldn't just rely on pressors for a trauma patient bleeding out everywhere. You had to fill the tank first before you squeeze the pipes.
That clarity really drives the right interventions. Okay, let's take this pump fluid pipe idea and apply it. We'll look at 4 really intense, common scenarios you wrestle with in the ER all the time. Let's start with one that perfectly shows both a fluid problem and a metabolic meltdown. Okay, DKA. Let's paint the picture of the what. Often it's a known type 1 diabetic, maybe young, comes in feeling incredibly sick. Profound nausea, maybe projectile vomiting, and that severe abdominal pain, which can really throw you off, right?
Oh, yeah. The abdominal pain can mimic appendicitis or something surgical. It's a big distractor.
They look sick. Tachycardic, maybe hypotensive already, and they've got that really distinct breathing, fast, deep.
It's a small respiration.
Key smalls, right.
Yeah.
And sometimes you catch that sweet, fruity odor on their breath, acetone. You check the sugar, and the glucometer just laughs at you. It just says HGH.
Or reads an error, yeah. So the why behind all this, it's a cascade. And it starts with an absolute lack of insulin. Maybe they missed doses, maybe they got sick with something else like an infection, and their body's insulin needs just skyrocketed.
And without insulin,
the cells are locked out. Glucose is the main fuel, but it can't get in. It's stuck outside.
so it piles up in the blood. That's the first major problem,
Well-
hyperglycemia and osmotic diuresis.
Right. Glucose levels climb like crazy, 600, 800, sometimes higher. This makes the blood incredibly concentrated, super hyperosmolar. The body's trying to fix it, so the kidneys start filtering out all that extra glucose.
The glucose pulls water with it.
Exactly. It's a powerful osmotic diuretic. Think of it like a water magnet. Every bit of glucose the kidneys dump, it drags huge amounts of water out with it. And not just water, key electrolytes too, especially potassium, sodium, phosphate. They all get flushed out.
Which leads to just massive urine output, gallons sometimes. That's the profound dehydration. They're effectively hypovolemic because they've peed out all their volume.
Yeah.
This is a major fluid problem.
Huge fluid problem. And at the same time, because the cells are starving, remember, they can't get the sugar, the body flips into survival mode. That's the second critical breakdown, ketogenesis and acidosis.
Okay, so no sugar for energy. The body starts burning fat instead.
Fat and muscle, yeah. It's breaking down alternative fuels. But the byproduct of fat metabolism, these acidic compounds called ketones,
And they build up.
they build up incredibly fast. So fast, they completely overwhelm the body's natural bicarbonate buffering system. This massive accumulation drives the blood pH way down. We're talking severe metabolic acidosis. And that fruity smell, that's acetone, one of those ketones, literally being exhaled as the body tries to get rid of it.
Which leads perfectly to the third piece,
Yeah.
that characteristic breathing, the compensatory breathing, the Kussmaul respirations.
It's the body's desperate attempt to fix the acidosis. The lungs are the fastest way to tweak pH. See, acids and CO2 are linked. By breathing really deep and fast, Kussmaul's the patient is trying to blow off as much CO2, which acts like an acid, as possible. They're trying to raise the blood pH back towards normal.
It looks exhausting.
It is exhausting, but it's a vital compensation. Now, here's where the real critical thinking comes in for the ER nurse. The part where you anticipate disaster. The critical potassium shift.
This is the big one, the one that can kill them if you miss it.
This is the absolute pearl. This separates just following the protocol from truly understanding what's happening. Because of that severe acidosis, the body tries to buffer itself by shifting hydrogen ions, the acid H+, into the cells. But to keep the electrical balance, for every H+ that goes in, a potassium ion, K+A, gets forced out of the cell and into the bloodstream.
So when you check that first potassium level, the serum K+, it might actually look normal or even a bit high.
Exactly. It might be 4.0, 4.5, maybe even 5.5, but that number is a total lie. It's masking a massive total body potassium deficit. They've been pouring potassium out in their urine for days.
Wow.
The only reason the serum level isn't in the toilet is because the acidosis is artificially propping it up by pushing intracellular K+ out. The danger comes the second we start treatment, specifically the insulin drip.
Because insulin lets glucose into the cells.
And potassium, too. Insulin acts like a key for both. The minute you start that insulin drip, all that potassium that was sitting in the serum, it rushes back into the starving cells.
And the serum level plummets.
Plummets. Fast, like within 30 minutes sometimes. You can get profound hypokalemia, which leads straight to potentially fatal arrhythmias like VTach or VFib. You have to anticipate this.
Okay.
This is why DKA protocols are so specific about checking potassium before starting insulin and often starting potassium replacement, even if the initial level looks okay, usually if it's below something like 5.2 MEQL.
That understanding completely changes how you approach the interventions. So connecting the dots, that profound osmotic diuresis, the hypovolemia, IV fluids are priority number one,
Yeah.
right? Massive amounts.
Absolutely. Aggressive rehydration is the first life-saving step. You've got to treat the hypovolemic shock first, restore perfusion, get blood flow back to the kidneys, and actually, the fluids themselves help dilute the blood sugar and flush some of it out, reducing that hyperosmolarity. We usually start with normal saline, maybe a liter bolus, sometimes more, right off the bat.
Then comes the insulin drip. And let's be really clear about the main goal here. It's not just about the sugar number.
That's critical. The number one goal of the insulin drip in DKA is not just lowering the glucose. I mean, that happens. It's a side effect. The primary goal is to stop ketogenesis, to flip that metabolic switch back from fat burning to glucose burning.
Tell the body, stop making acid.
Exactly. Stop making ketones. Once you stop the ketone production, the acid production stops and that metabolic acidosis starts to resolve. The closing of the anion gap is actually a better marker of resolution than the glucose level itself.
Which means sometimes you actually have to add dextrose to the IV fluids later on, even while the insulin drip is still running.
Vital point. Once the blood glucose starts coming down, maybe below 250 or 200 milli-GDL, depending on your protocol, you have to add dextrose, like D5 or D10, to the maintenance fluids. Because you need to keep the insulin going to shut off those ketones, but you absolutely cannot let the patient get hypoglycemic.
Or risk cerebral edema.
Right, especially in kids or young adults. Correcting the sugar or the osmolality too fast can cause fluid to shift rapidly into brain cells. It's rare but devastating. That's why those hourly neurochecks and lab draws are non-negotiable.
And finally, circling back to that potassium, constant vigilance and proactive electrolyte replacement is key.
You are glued to those hourly electrolyte results. You're often starting potassium replacement early, sometimes even when the initial K+ is normal-ish, because you know the insulin is going to make it drop.
And if it does drop too low, say below 3.3,
you have to stop the insulin drip. Full stop. Fix the potassium first, get it back up above 3.3 before restarting insulin. The risk of cardiac arrest is just too high otherwise. That anticipation, knowing what's coming, that's everything in DKA management.
Okay, let's shift gears. We went from a problem of volume loss, hypovolemia in DKA, to a problem of volume backup. This is classic pump failure. Acute decompensated heart failure, or ADHF. The what here is that picture you see all the time. Often an older patient, known history of heart failure, sitting bolt upright in the stretcher, literally gasping for air. They look terrified.
Much like diaphoretic.
Yeah. You hear crackles everywhere, maybe some wetting too, that cardiac asthma. And frequently, they're incredibly hypertensive. The BP might be, 210 over 110, just sky high.
And the why, it's fundamentally pump failure. The left ventricle is too big. It just can't handle the volume. It can't push effectively against the pressure in the system, so everything backs up. And you nailed the key driver in this acute crisis, that massive blood pressure.
So that high BP means acutely increased afterload.
Precisely. Afterload is basically the resistance the heart has to pump against to get blood out into the body. If the arteries are clamped down tight, vasoconstricted, and the pressure is sky high, it's like that weak heart muscle is trying to push water through a tiny, pinched garden hose.
Impossible.
Almost. The heart fatigues immediately, cardiac output plummets even further, and it becomes this vicious cycle. The hypertension is both a symptom of the stress and a major cause of the worsening failure.
And the direct, terrifying consequence of that blood backing up because it can't move forward? Pulmonary edema.
Right. Because the left ventricle can't eject blood effectively, pressure builds up backward into the left atrium, then into the pulmonary veins, and finally into the pulmonary papillaries surrounding the alveoli.
Tiny air sacs in the lungs.
Exactly. That pressure, the hydrostatic pressure, gets so high, often way over 25 millimeters of mercury, it physically forces fluid right out of the blood vessels into the lung tissue itself and then floods into the alveoli.
So the patient is literally drowning.
They are drowning in their own fluids. That's the flash pulmonary edema. That's why they can't breathe, why they're sitting bolt upright while you hear those wet crackles.
Okay, so knowing that physiology, the failing pump, struggling against massive afterload, causing fluid backup into the lungs, our main interventions all aim at basically making the pump's job easier and getting that fluid out fast. Let's start with nitroglycerin.
Nitro is absolutely crucial here, primarily because it tackles that resistance, that afterload. It's a powerful vasodilator. Works in two main ways. First, it dilates the veins' venodilation.
Okay.
This basically lets the veins hold more blood, like creating a bigger reservoir, so less blood returns to the already struggling heart. That reduces preload, the amount the heart has to stretch to fill, makes the initial filling part easier.
But the more critical effect in this hypertensive emergency
Is the arterial dilation. It relaxes the arteries, drastically cutting down that afterload we were just talking about. Suddenly, the resistance the heart has to pump against plummets. The heart can actually eject blood more effectively, cardiac output improves, and that rapid backup of pressure into the lungs, it stops. Or at least slows way down. It's like unkinching the hose. It's an immediate mechanical fix for the pressure overload.
We also use diuretics, like Lasix, furosemide, right? To get rid of the total body fluid.
Definitely. Diuretics are essential for removing that excess fluid volume from the whole system.
Yeah.
But here's a common pitfall, especially for newer nurses. Don't expect Lasix to work instantly like nitro does.
Right, it takes time.
It takes time, it has to circulate, get to the kidneys, start working. You're looking at maybe 15, 20 minutes before you even see urine output start to increase, and peak effect is much later. That's why, acutely, we lean so heavily on the immediate hemodynamic effects of nitro and BiPAP to stabilize things, while the Lasix works on the longer-term volume removal.
Okay, let's talk about BiPAP, bilevel positive airway pressure. This is often a lifesaver in ADHF, but someone might just think it's helping with breathing. But the physiology is more about the heart failure, isn't it?
Absolutely. Understanding the why behind BiPAP here is so important. It provides two huge hemodynamic benefits beyond just supporting oxygenation. First benefit, that positive pressure it delivers. It literally pushes air into the lungs under pressure.
Okay.
This raises the pressure inside the alveoli, making it higher than the pressure in those surrounding leaky capillaries. That pressure difference acts like a physical squeeze, pushing the fluid out of the alveoli and back into the bloodstream, back into the capillaries. You are mechanically reversing the pulmonary edema.
Wow, okay, that's a direct fluid shift. What's the second benefit?
The second benefit has to do with preload. By inflating the lungs under positive pressure, you increase the overall pressure inside the chest cavity, the intrathoracic pressure.
Right.
This increased pressure gently squeezes the big veins returning blood to the heart, primarily the vena cava. This reduces the amount of blood flowing back to the right side of the heart.
So less blood comes back.
Less blood comes back, which means less blood eventually gets to the failing left ventricle. It's like giving the heart a break. It's a non-drug way to reduce preload, immediately decreasing the strain on that overwhelmed pump. So when you put that BiPAP-P mask on, you're hitting the fluid in the lungs and reducing the workload on the heart all at once.
All right, moving from the heart and lungs to the brain. An organ with absolutely zero tolerance for perfusion failure. Ischemic stroke. You could argue this is the ultimate time-sensitive emergency we see.
Absolutely. Time is brain, literally.
The what is that sudden onset of a focal neurological deficit. You know the signs fast. Facial droop, arm drift, speech changes, time, that sudden slurring, the one-sided weakness, and the single most critical piece of information you need.
Last known normal. The exact time those symptoms started, or the last time someone saw the patient acting completely normal. Everything hinges on that time.
And the why here. It's a blocked artery in the brain. Simple plumbing problem, right? But the consequence is immediate, localized perfusion failure. Brain cells die incredibly fast without oxygen and glucose.
And we think about the damaged brain tissue in two distinct zones. Our entire treatment strategy revolves around these two areas.
Okay, first zone.
The ischemic core. This is the brain tissue that was directly supplied by that blocked artery. Blood flow is cut off, completely or almost completely. These cells die very, very rapidly, sometimes within minutes. This damage, it's irreversible. We can't save the core.
But surrounding that dead zone?
Yeah.
That's where the battle is fought.
Exactly. Surrounding the core is the penumbra. This is the tissue we can save. It's injured, it's not working right, that's why the patient has symptoms, but it's still getting just enough trickle of blood flow from nearby collateral arteries to stay alive. Barely.
So it's stunned, but not dead yet.
Precisely. It's fragile, at-risk tissue. And the entire goal, the only goal of acute stroke treatment, whether it's meds or a procedure, is to restore blood flow fast enough to save that penumbra before it dies and becomes part of the core.
Which explains the relentless focus on time. We always say the longer the delay, the larger the core.
Every single minute counts. Millions of neurons in that penumbra are transitioning towards death every minute that artery stays blocked. That urgency drives everything. It's why we use thrombolytics like TPA, tissue plasminogen activator, or alteplase.
The clot-busting drug.
Right. The logic is pure perfusion. Dissolve the clot, open the artery back up, restore blood flow, and salvage that threatened penumbra.
And that's why those time windows for giving PPA, usually within 3 hours, sometimes up to 4.5 hours from last known normal, are so incredibly strict.
It's a constant risk-benefit calculation. TPA carries a significant risk of bleeding, especially in the brain. But the potential benefit of saving brain function by reperfusing the penumbra is huge, but only if we get it in quickly before the penumbra dies off.
And now, increasingly, especially if it's a big clot in a major artery, a large vessel occlusion, or LVO, we're moving towards thrombectomy.
Mechanical clot retrieval, yeah. Going in with a catheter and physically pulling the clot out. This can sometimes be done much later, even up to 24 hours in selected patients, but only if advanced imaging confirms there's still a significant area of salvageable penumbra worth going after.
Same goal, though. Open the pipe, save the penumbra.
Same exact physiological goal, just a different tool. Reperfusion is the name of the game.
Okay, now here's a management point that can feel really counterintuitive, maybe even scary for nurses. Permissive hypertension. If a stroke patient hasn't received PPA, we often let their blood pressure run much higher than usual, sometimes up to 220 systolic. That feels wrong. Why do we allow that? Isn't the bleed risk huge?
That's a fantastic question, and it goes right back to the penumbra. Remember that threatened tissue is only surviving because of marginal blood flow through tiny, often narrowed collateral vessels.
Okay.
If you drop the patient's overall systemic blood pressure too much, the pressure pushing blood through those compromised collateral pathways also drops.
So you need that high pressure to kind of force blood through those tiny side roads to reach the starving penumbra.
Exactly. That higher blood pressure maintains a critical perfusion pressure to the very tissue we're trying to save. If we aggressively lower the BP down to, say, 140 systolic, we might feel better about the theoretical bleed risk, but we could inadvertently kill off the penumbra by cutting off its only lifeline.
So we tolerate the higher pressure because ensuring perfusion to the salvageable brain tissue is the absolute top priority in that moment.
It's prioritizing localized cerebral perfusion over generalized systemic numbers. It's a calculated risk, but it's based firmly in the pathophysiology of the penumbra.
But critical distinction if the patient did get TPA.
Then the game changes completely. Because TPA significantly increases the risk of hemorrhagic conversion bleeding into the stroke area. Now that high pressure becomes a major liability.
So the goal shifts.
Immediately. We shift from permissive hypertension to controlled blood pressure. We need to keep it below a safer threshold, usually less than 180 to 105, to minimize that TPA-related bleed risk. This often means using IV antihypertensives, maybe a nicardipine drip or labetalol pushes, to actively manage it.
So the intervention TPA or no TPA totally dictates the blood pressure goal. Understanding that why is crucial.
Absolutely key.
Okay, let's bring it to the airway. Another critical emergency, the asthma exacerbation. The what is usually pretty clear. Often a younger person, known history of asthma, comes in acutely short of breath. They might be sitting leaning forward, tripoding.
Struggling to speak, yeah, using accessory muscles in their neck and shoulders to breathe.
Right, you see those neck muscles straining. They can barely get out maybe 2 or 3 words at a time. And you hear that characteristic wheezing, sometimes even without a stethoscope.
Now, asthma itself is a chronic inflammatory condition, right? But the acute exacerbation, the flare-up, involves 2 distinct things happening physiologically that narrow the airways. And you have to treat both of them, or the patient's just going to bounce right back.
Okay, what's the first process, the immediate one?
That's bronchoconstriction, the spasm. The smooth muscles that wrap around the small airways, the bronchioles, they suddenly clamp down hard in response to whatever triggered the attack. Could be an allergen, a virus, cold air, exercise.
And that muscle spasm physically squeezes the airway shut.
Exactly. It acutely narrows the lumen, traps air in the lungs, and causes that classic high-pitched wheezing sound as air tries to force its way through the tiny opening. This is the immediate scary part.
Got it. And the second process, you said it's more insidious.
Right. This is the inflammation. The same trigger that caused the muscle spasm also kicks off an intense inflammatory reaction in the lining of the airway.
So swelling.
Swelling, redness, edema, yes. And on top of that, the airway starts producing loads of thick, sticky mucus. So now you have muscle spasm plus swelling plus mucus all clogging up the airway. And crucially, this inflammation lasts much longer than the spasm. It can stick around for hours, even days, after the initial wheezing seems better.
Ah, okay. So if you only treat the spasm.
You're missing half the problem. The patient might feel better initially, but that underlying inflammation is still brewing and they'll likely relapse hours later when the short-acting bronchodilator wears off.
Makes sense. So our interventions have to hit both pathways. We usually start with the fast fix, right? Beta agonists like albuterol nebulizers or inhalers.
Yep. Albuterol is a beta-2 agonist. It works directly on those smooth muscles wrapped around the bronchioles. It tells them to relax, causing bronchodilation. This rapidly reverses that acute muscle spasm.
So the wheezing gets better, they feel like they can breathe easier.
Exactly. You see their work of breathing decrease, maybe their peak flow improves. It provides that immediate, often dramatic relief.
And this is the key point, albuterol does absolutely nothing for that underlying swelling and mucus production.
Zero. Nada. That's where the corticosteroids come in. Whether you give oral prednisone or IV Solimedrol, these are your anti-inflammatory powerhouses.
So they tackle the swelling and the mucus.
Right. Their job is to calm down that whole inflammatory cascade happening in the airway lining, reduce the edema, decrease the mucus. They treat the root cause of the persistence and the relapse risk. But, and this is super important for clinical timing, steroids are slow.
They don't work right away.
Not at all. Their effect is significantly delayed. You're talking maybe 4 to 6 hours, sometimes longer, before you see their full anti-inflammatory benefit kick in at the cellular level.
So if you have an asthma patient who sounds way better after just a couple of albuterol nebs, you can't just discharge them thinking they're fixed if they haven't gotten their steroid dose yet.
Absolutely not. That improvement is just the muscle relaxing. The inflammation is still there, waiting to flare back up. The steroids are the essential piece that actually treats the exacerbation properly and prevents them from bouncing back to the ER later that day or the next. Understanding that delayed effect is critical. You never discharge an acute asthma exacerbation without ensuring they've had steroids and have a plan for continuing them.
Okay. And often, especially in moderate to severe attacks, we add another type of bronchodilator, right? Anticholinergics, like ipratropium, often given together with albuterol as a duoneb.
Yeah, they provide an extra punch. They work through a totally different mechanism than albuterol. They block the effects of the parasympathetic nervous system on the airways.
Which normally does what?
Normally, the parasympathetic system tends to cause some bronchoconstriction and increase mucus. So by blocking it with ipratropium, you get additional bronchodilation and potentially dry up secretions of it.
So albuterol hits one pathway, ipratropium hits another?
Exactly. You're attacking that smooth muscle spasm from 2 different angles, trying to maximize the opening of the airway lumen. Gives the patient the best shot at recovering their airflow while the steroids start working on the inflammation in the background. Hashtag tag tag outro.
Okay, wow. We've covered a lot of ground there. 4 really intense critical situations you see constantly. DKA's metabolic and fluid chaos, ADHF's failing pump, the race against time and stroke, and the 2-pronged airway attack in asthma.
And hopefully the common thread that came through is how understanding the underlying why, the pathophysiology, really elevates how you handle the protocols and interventions.
Totally. It's not just about checking boxes. Knowing why you're giving massive fluids first in DKA, osmotic diuresis, hypovolemia, even before focusing on the sugar number.
Or why that last known normal time is so sacred in stroke, saving the penumbra.
Or why BiPAP isn't just for oxygenation and heart failure. It reduces preload and pushes fluid back.
It changes everything. Your actions become deliberate. They become predictive. You're not just reacting. You're anticipating based on the disease process itself.
Yeah, it absolutely shifts your practice.
Yeah.
You move from just executing orders to actively thinking, okay, given this pathophysiology, what's the next likely failure point? What do I need to watch for before the alarm goes off? That's real critical thinking in the ER.
It helps you make sense of all the data points coming at you, right?
Yeah.
The vitals, the labs, the monitor, the patient's appearance. It connects them into a coherent story of what's actually breaking down at the cellular level.
So let's leave you with a final thought to chew on during your next shift. We talked about DKA, right? That massive fluid loss from osmotic diuresis causing severe hypovolemia. Now think about the impact of that profound dehydration, that lack of perfusion specifically on the kidneys. They're already working overtime trying to filter out all that glucose, based purely on that underlying pathology, the severe volume depletion. What's the next major organ system failure you'd be most concerned about monitoring for in that DKA patient?
Good question.
And thinking about that potential complication, what specific intervention, beyond just fluids and insulin might you proactively ensure is considered or ordered to protect that organ system? Something to mull over.
Keep digging for the why, always. It really does make all the difference in the care you give.
Couldn't agree more. That's all for this deep dive. We'll catch you next time.